Hello, I'd like to welcome everyone to this evening's program. I'm Karen Parry. I'm the director at the East Brunswick Public Library. I also manage the library's Just for the Health of It Health Literacy Initiative. Tonight's program, Understanding Amyotrophic Lateral Sclerosis, is our first program on this topic, and we are so honored to be able to actually hold this program in May, which is timely because May is ALS Awareness Month. And the purpose of this program is to bring awareness to ALS so that people understand what this disease is and the latest treatments for this particular disease. I hope that for those of you who have lived in East Brunswick, you've had a chance to visit our ALS awareness table in the lobby of the East Brunswick Library, where we have an assortment of brochures and literature about ALS so that people can be enlightened about the latest treatments, nutrition, activities for daily living, and even support services for ALS patients, families, caregivers, and friends by MAC Angels, which provides support for those particular groups. And you can reach them at www.macangels.org. Tonight's program, Understanding ALS, will be taped and will be uploaded to YouTube, where you can view it anytime you wish. And it will also be uploaded to the library's health portal, justforthehealthofit.org. There will be, everyone will be muted during the presentation. However, you can ask questions by just clicking on the chat box. And at the end of the presentation, we will read the questions and the doctor will answer all your questions. So I am so honored to welcome Dr. Shan Chen this evening. Dr. Chen is a professor of neurology at Robert Wood Johnson Medical School. Dr. Chen received her doctorate in neuropharmacology at Columbia University Medical Center in New York City and completed her neurology residency training at JFK Medical Center in Edison, New Jersey. She also did a fellowship in neuromuscular fellowship training at the Johns Hopkins Hospital in Baltimore. So without further ado, I'm so honored and pleased to turn the program over to Dr. Chen. Welcome, Dr. Chen.
Thank you. Thank you for the invitation. So hi, everyone. Good evening. So tonight we're gonna talk about ALS, and then my talk will be very general understanding ALS. Any questions you can just type in, or if you want, so we'll answer them in the end. Okay. So first I want to introduce our ALS team. We have a multidisciplinary team at Rutgers University, Robert Wood Johnson University Hospital in New Brunswick. We're the largest one, the oldest ALS centers in New Jersey. And then in our team, we have neurologists, nurse, physical therapist, occupational therapist, social worker, dietitian, speech therapist. Also, we also collaborate with the pulmonologist and other the palliative care doctors, the GI doctors, the interventional radiologists, so forth. And they also are here. So towards the end, if you have any questions, so we have Dr. Ashley Wen also here. Thank you for joining us. So she's also neuromuscular trained neurologist, speech therapist Dory, dietitian Anna, and occupational therapist Tejal, physical therapist Courtney, and social worker Melissa, and nurse clinician coordinator Mary Ann. So if you guys, hopefully you don't need, if any of your friends, families have diagnosis of ALS, you're welcome to come to our clinic and we'll take care of you. So first, what's ALS? So amyotrophic lateral sclerosis. So it's a nervous system disease, like basically it's the nerve damage, especially the motor nerve. And it's degenerative disease, so it gets worse with time. And it's also called Lou Gehrig's disease. It's a famous Yankee baseball player who was diagnosed in 1939 at his 36-year-old birthday, and he died 2 years later. So since then, for almost like a decade, the exact cause of disease still not known. And we know that small number of cases are inherited, majority are sporadic, and often start with the muscle twitching, the weakness, either in the arm or legs, or even or in the bulbar area, like have trouble breathing or slur speech. Eventually, it will progress to other areas. Eventually, will progress to all the regions. As you can see here, on the left is normal. On the right, when the nerves are damaged, the muscle itself is okay, but if the nerve is damaged, the muscle will have the weakness, so it cannot contract. So potentially, it can affect any muscles. However, it does not affect the heart, and it doesn't affect the vision, the bowel, bladder, or sexual functions. And small subset of the patient will have some cognitive impairment, majority of them not. So also classically, there's both upper motor neuron and also lower motor neuron dysfunctions, means the brain, motor neuron, and spinal cord motor neurons are affected. However, there are some subtypes, depends on where the lesions are. For example, if it's just the upper motor neuron, it's also called PLS, or primary lateral sclerosis, or if it's just the lower motor neuron, it's called progressive muscular atrophy, or PMA. Or if it just affects the bulbar, it's called progressive bulbar palsy. Just affect the arms, called BAD, brachial amyotrophic diplegia, or just affect the legs, is the leg amyotrophic diplegia, or like flail leg. So all these subtypes are not as common as the classic ones. It's probably about 20 to 30%. And exact mechanism is not known. There are many pathogenesis pathways implicated. Could be glutamate excitotoxicities, means there's some glutamate toxicities, or their protein misfolding, aggregation. It could be impaired protein degradation, or oxidative stress, axonal transport abnormalities, inflammations, the aberrant RNA metabolism, mitochondrial dysfunction, or endoplasmic reticulum stress. So maybe all these pathways intertwine to cause the ALS. So as you know, the diagnosis often is the indirect winding path. On average, it takes about 12 months from the onset of the symptoms until the diagnosis. So with if you see, luckily enough to see a neuromuscular specialist, you might shorten it by just the couple of visits. So it includes the very comprehensive history taking, comprehensive detailed physical neurological examination. Often we do the EMG, and we also use the imaging study, the lab study, the blood work, or spinal tap to rule out ALS mimics. So what's the EMG nerve conduction study? It's really to test your nerves and the muscles. Basically, we use electrical stimulation to test the nerves and put a little needle in your muscles to check their strength. So it should be done by a well-trained neuromuscular specialist, because often if you go to some general neurologists who might specialize in Parkinson's, then maybe their test is not sophisticated enough to diagnose. So the referral is really highly recommended for this disease diagnosis. The MRI, we all know. So main thing is to really rule out the brain cancer, the spinal cord, pathologies, herniated discs, and other mimics of ALS. The blood work, the urine test, and also spinal tap. So we'll put the little needle into your spinal, in between the spine, the vertebra, and then take out some of the fluid. It sounds very scary, but actually it's pretty safe. Both we can do at bedside, and also even safer, we use the interventional radiologist to do it under fluoroscopy. And very rarely we need a muscle biopsy or nerve biopsy if your diagnosis is not very clear. So just list some of the facts. So basically I want to tell you guys it's pretty rare, and 90% of case has no family history, and the average of diagnosis 55. And but we do see some younger folks, and also the oldest I saw is 105-year-old. Approximately 6,000 people diagnosed each year, so 16 people a day. And about 31,843 Americans live with ALS. And gender is one risk, like 20% more common in men than women. Also the age, like if people live up to 85%, 1 in 300 chances, like people will develop the ALS, because it's similar like Alzheimer's, Parkinson's, they all belong to this neurodegenerative disease, means like aging of the motor neurons. And here, some people often ask, like, is there anything I did wrong in the past? Like maybe it's some exposure to the toxins, maybe like some kind of occupations, viral infections, smoking, excessive exercise, electrical shocks. But really we see from all kinds of occupations that people can develop the ALS. And the mean survival of this devastating disease is only 2 to 5 years, but some variant may have longer survivals, and we've seen people have 10 years of survivals in our clinic. And mainly majority of people eventually will, when the disease affect their breathing, and so basically they will develop the respiratory failure, and in addition to the arm and leg weakness, so that will be probably more advanced. And so far I put it 2, but really it was like 4. Why do I say that? So many trial fails, still no cure, and no drugs will reverse. So this happens a lot when we see the patient, is that I don't feel it's working. I don't feel stronger, but really no drugs can make it stronger. There's no reversal. All the medications so far we developed just make the progression slower, make longer survival, delay the process to develop the disability, but there shouldn't be any drug to reverse it. If there is, then maybe the diagnosis was not right. So there are 2 categories of therapies. One is called disease-modifying therapy, means like they can reduce damage to the motor neuron, prolong survival, slow the decline, and also, like I said, increase the time to the needs for tracheotomy or ventilation. And their second category is symptomatic treatment, means like there are so many other symptoms, non-motor symptoms, that we can treat with medications, even though they're not directly targeting the motor neuron damage. So like even before April, we have 3. So there's Riluzole, like approved in 1985. There's Radicava. I'm sure like some of you with diagnosis with ALS is on both Riluzole, Radicava. And so there are 2 forms, IV form and or like oral solution. And there's Ralivril, which was approved by FDA in September 2022, but withdrawn in April 2024 due to the confirmatory trial shows it's not beneficial. So therefore, the company decided to withdraw. But your drug's still available if you want to have access to it. It's safe, but then it's questionable. Will have some like benefit. And Torphysin is a newer one last year, but that medication is injected to the spinal cord, like not spinal cord, so it's kind of spinal fluid, but it's only specifically for SOD1 type of ALS, so it's a genetic form ALS, and it has been showing very positive results. So it's antisense RNA medications. And the most common one we still use for all our patients is called Riluzole. And the indication definitely probable, like symptom onset of less than 5 years, if the vital capacity more than 60 and no tracheotomy. But even for the one who doesn't meet criteria, we still recommend it, may also have some benefit. And the benefit is really like to prolong the survival with the modest degree. However, like especially for the late stage, it can prolong survival. And also the longer you're on riluzole, especially when you have received this cumulative dose of higher than 16,800 milligram, the benefit is long, even better. So the second medication is Radicava, like I said. So you guys probably all know, you either infusion or medications first thing in the morning after the fasting, and then you do 14 days on, 14 days off, and then you do 10 days on, 14 days off. So it's pretty well tolerated, especially with the oral solution form. There's some newer data suggesting maybe IV form is better, but the consensus is still the both are approved. So it's a free radical scavenger. So it's reduced the oxidative stress, and it prolongs the survival by slow the there is a marker called ALS FRS, like we score you every time you come in with your functions. So there are 12 functions, each function is 4 points, total is 48. And then we try to stabilize your score, and this medication will just slow this, deterioration of the score by 33%. So therefore, we still suggest to all the patients with ALS, especially early mild ALS. So I'm not going into the details of this, I kind of mentioned it. And a lot of visits, when you come to the clinic, what we do is to treat your symptoms. All these symptoms like muscle spasm, shortness of breath, spasticity, salivary is a big one, fatigue, thick mucus, pain, pseudobulbar affects means because of this, not only the motor neurons are affected, also have this disinhibition or uncontrollable cry or laughters. So we have medication for that, and also FDA approved called Nuedexta, and also some antidepressant helps. Some so basically we can use antidepressants or the Nuedexta, pretty effective. And a small set of the patient also have the frontotemporal dementia, means that they have some cognitive impairment that can also be controlled by the medications. And there's also sleep problem, constipations. So the list is on, everybody is different. This disease is really a disease of spectrum, as you can tell, the regions affected, the symptoms, the progression. Some people will be stable and then deteriorate. Some people deteriorate and stable. So yeah. So where do you find a research trial? You can go to clinicaltrial.gov/ALS, news.org, ALS.org research. And so basically a lot of this website has clinical trials, has research trials. And there's also Healy platform trial. So they can, so basically we can test the multiple treatment at the same time. And also you kind of get higher chance of being randomized to the medication rather than placebo. And there has been all these medication have gone through these platform trials, and some of them still ongoing, and some failed. And there are also some non-therapy trials ALS Focus is for patients and caregiver surveys. There's a registry and the biorepository, means we would like to collect the ALS patients' blood sample, the spinal fluid, the biopsy results, and to help research and develop the new therapeutic agent and many others. And there's also registry. So we want to know all the information, epidemiologies, risk factors, occupational, and just the more data we collect and the more understanding we have for these conditions. A lot of people ask for alternative treatment, the herbs, the B12, the stem cells, and all that. So none of them are approved by FDA. This is just limited data. And for the caregivers and for the patients, how do we live with ALS? So very important to build a support network. So you can find, the first thing you find is ALS certified treatment centers like us. There are 2 others in New Jersey, in every state, maybe in every state, right? I don't know, like Marianne can answer. So check into the chapter resources, join a support group. So Marianne and Debbie run like a support group for all the ALS patients. We do the ALS walk and some charity work, and also just build a care team, and then fundraising. So you're not fighting this alone. So we all help you along the way, and there are all kinds of care services so equipment loan program. There's clinic, there's education support group, even home visits. And so this impact of ALS is called PALS, patient, caregiver, families, everybody needs to be taken care of, because it's, such a devastating disease. And then it's very difficult to deal with, especially when the disease progress and, there are different symptoms come up, different issues come up. There's also financial impact, and, you need to develop a plan. And all these resources, so I guess I'll just stop here. And then if you guys have any questions, you can ask us, and anybody on the panel, if you have questions, you can ask us too.
Actually, doctor, I'm seeing one question here. It says, very nice talk. How can patients with a concern make an appointment with you?
So they call our scheduling number, or
yeah, they could call our scheduling number, which is 732-235-7733, or they can call me, the nurse coordinator, at 732-235-7331. I could put those in the chat if you'd like.
Yes.
Oh, I'm already there. Okay, great.
Yeah, so if you contact us, we'll bypass all the a lot of hurdles to get access, and then either me or Dr. Wang gonna evaluate you as soon as possible, usually within a couple of weeks, and then we do the EMGs, and we order a bunch of tests, and then once we confirm, and then we'll just put you on the list to be seen by the whole team.
Doctor, there's one more question. It says, why is there an uptick in ALS diagnoses?
So I think it's probably first things first, right? So more awareness, and also we do see this happens too. I think it's up and down. Sometimes you just see all of a sudden we have a lot of ALS patient was diagnosed with ALS, and then but on average is the incidence is about 1 in 100,000. And the prevalence is 3 in 100,000. So probably patient was diagnosed earlier now compared to before.
Thank you, doctor. We have one more question. Some people felt the Relivro worked for them, so they can still get it if they feel there's been some help. We know it could be true given the individualness of the disease.
I think so. So it's pretty safe to take. It's tolerable, and then the phase 2 trial was actually positive, means it did show some clinical significant benefit. And so I think I always tell my patients depends on how you think, right? So if the statistics shows that it's benefit to only very small subgroup of the patient, which by the way, they haven't done the subgroup analysis yet. I think they're still going to do it. So so it's up to, so we give the option to the patient if they want to. I think the companies will actually give them for free. Am I right, Marianne? And then also for the patient who has been on clinical trial or has been on open label extension of the clinical trial, they're also available for them. But then the company withdraw the medication from the market. So just don't know the future.
Okay.
It can't be newly prescribed, but it can be extended for those that are on it for about 3 more months.
Someone else wrote, due to the individualness of the illness, thoughts on how they can find these treatments to work across the population.
That's true, because individually you probably won't tell the difference, right? Like whether you are even like we cannot predict whether they're rapid progressor or like slow progressor. So if you take the medication, you, for example, the patient progress rapidly, but you don't know without the medication, you may progress even more rapid, right? So individually, you won't tell. But the things that like, just on the population study, that's when we do the clinical trial, we have 2 population, like one take medication, one doesn't take medication, then they can compare. So that's how the clinical trial works. But in both groups, like the one take the placebo or the one take the medication, they all different. Some people are fast, some people are slow. So every individuals have their own pace of the progression. But I would say because we practice just evidence-based, so what we can do is just to follow the clinical trial, follow the FDA. Yeah.
One other question, what is the difference between ALS and PLS?
So the ALS is the damage occurred in both the upper motor neuron, means the brain, and also the spinal cord. So when we move the muscle, right, so the motor neuron in the brain will control the motor neuron in the spinal cord, and then will transmit the signal to the muscle. So PLS means like you just have upper motor neuron, means the brain, the motor neuron is damaged. So these patients with PLS often have a lot longer survival, a lot slower progression. And so there are almost no trials on the PLS. So often we just either leave them alone or not leave them alone. I mean, in terms of the treatment, often I still recommend the riluzole, even though there's not much data support that, just intuitively, but they're also fine without the riluzole.
Does Robert Wood Johnson have any trials for ALS?
We used to. We participate in this Amyotrophic trial. Actually, we enrolled the patient. So currently, we don't have any trials, but we're preparing to join, some of the trials, especially the platform trial. So I know there are nearby cities, the Philly, Columbia, some like big centers is Boston, but often I would say for individual patient, you need to kind of like balance, because first of all, there's cost, right? You need to have frequent visits. So if it's too long distance, that may have some inconvenience. And a lot of trials failed. I would still encourage participants, but then it has to be individual based. And I think if you're SOD1 positive, I think right now our center, we don't do intrathecal tofersen, but then we refer you to Columbia Medical Center.
Okay. What are your thoughts on patients having ventilatory support and feeding tube to support them?
So basically, so we have nutritionists and we have speech pathologists. So we also have a pulmonologist work with us, and then there are certain criteria when they will need the feeding tube. And the study has shown sometimes we even do proactive feeding tubes rather than until they're really late. And then so they help them to gain some weight, calories, nutrients, medications. Also the medication for the breathing part, we refer them to the pulmonologist. Often they start with measure their pulmonary function, and then as some point they may need some what we call non-invasive ventilation, means the BiPAP, and depends on the wish. Like some people use invasive ventilation, and so we often just refer the question to the pulmonologist. So it's really important to see the pulmonologist like at baseline, also every few months, because a lot of patients just like say, I don't have any trouble breathing, like I won't bother to see them. So it's important to get a baseline. Yeah.
Okay. Are there certain regions where there is a higher prevalence of ALS seen, such as globally?
Globally, I don't have the data. Dr. Wen, do you know any data on this geographically? I know like in the beginning there was like a small island, like they have very high prevalence. Yeah, I don't know the answer.
Yeah, I don't know. I don't know the answer either, but I've heard like there's some, I don't know. I mean, it's all speculation. Like people have found like certain areas, maybe with certain like more polluted areas, had small pockets of ALS that are more prevalent, but nobody knows for sure or what the the cause is.
Did Stephen Hawking, he's the famous physicist, have ALS? And if he did, he lived for 55 years with it. Do you know anything about that?
I know, right? So it's like really kind of very atypical. Yeah, we once in a while we run these typical cases, but I can't answer because I never examined him. I didn't do his EMGs. It definitely looks like he's progressing just slowly, and he has a lot of like support. But yeah, so it's definitely one of the outliers, I would say.
Any more questions for the doctor?
Or for the other panelists,
The
we
other
have an amazing group who has a lot of experience too with the ALS, and then we encounter frequently like a lot of some physical therapists, occupational therapists. If they don't have a lot of experience with ALS, you will just let them to do the weight training, a lot of like strenuous exercise to build the muscles, and so yeah, really they should come to the our center or other centers for more like expertise.
We have another question about the palliative approach, and someone had written in that many of our patients feel like this disease is very hard to navigate, different doctors, etc. Have you thought about a palliative approach? And I guess with that, you can also talk about nutrition and lifestyle, talk a little bit about all of that, and maybe your panelists as well, and what they can add to living with ALS.
Yeah, so the palliative care, Marianne, I think we have some collaboration with the palliative physicians. So yeah, and then Melissa, like social worker too, like we discussed, start with them, like very early on what their wishes, whether they want tracheotomy, the feeding tube.
Yeah, some centers have a palliative care nurse on their team. We're not that fortunate just yet, but we have a relationship with the palliative care service at Robert Wood Johnson, as well as some of the local visiting nurse associations. So we're referring on a case-by-case basis.
Hi, Dr. Chen. I have one question for you. Can you hear me? This is Winnie.
Oh, hi.
Dr. Chen, I have seen you in some cases you had given some IVIG. Is that an off-label to use for ALS or not?
Oh, okay. Good questions. We have this come up too. So, like for ALS, there's not one biomarker that can diagnose, okay, this is cancer. It's not, ALS, not like cancer, right? They can do the, like the tissue pathology, but then very, very hard to take the biopsy of the brain or spinal cord to do it. So basically, like we said, we do the EMG and we want to rule out any other possibilities, extensive blood work, and then sometimes it's still very hard to figure out whether it's ALS or there's another condition called multifocal motor neuropathy or MMN. It also affects the motor strength, and it often on one side, not the other side, similar like ALS, and often doesn't affect the sensation And it can be progressive if you don't treat. However, the difference is that condition is treatable and treatment is IVIG. So if we see some patient who just have focal weakness limited to like one arm and very atypical, so we use IVIG, not just me, like, you know, across the board. We give like 3 to 6 months try to see whether they can respond, because that ALS mimic multifocal motor neuropathy is very responsive to IVIG. So if they respond, then we continue to treat, and if they don't respond, then we say most likely it will be ALS. So for ALS, there's also definitely probable and possible. As you can see, like, you know, it's very, very, very few patients we can see definite in the early on. So that's why it's kind of like ongoing like process. And then, yeah, but majority of the cases, like if they see the neuromuscular specialist, is pretty like, you know, accurate. Yeah. But we definitely see patients who came to us, they already underwent the cervical surgery, spine surgery, the lumbar surgeries, thinking it could be from the cervical lumbar herniated disc, but didn't improve, and then they come to us. So basically, it went through these unnecessary procedures. But you know, IVIG is, yeah, we definitely use in some of the typical cases.
All right. Well, I'd like to thank you, Dr. Chen. This has been a wonderful presentation, and I'm sure very helpful to so many people, and will be helpful to so many people. It will be on the library's health portal, justforthehealthofit.org, and like I said, as well as on YouTube. And I'd like to thank you, Doctor, for taking time out of your busy schedule to give back to the community and to realize the importance of a patient who has health literacy in being able to take proactive measures in managing their own health so that they have the best health outcomes. So thank you to you, and thank you to your team for all that you do for our community. And again, I'd like to thank everybody and wish you all a very good night.